All right, good morning. So I wanted to talk about VISI and DISI because they're conditions that are definitely due to different deficiencies, but they're very much related anatomically and biomechanically. So I hope that by the end of this talk we can all say that we conquered VISI and DISI. That's what that means, by the way, for anybody. So start with some anatomy. Proximal row consists of the scaphoid, the lunate, the triquetrum, and the pisiform. There are actually no tendinous insertions on the proximal row, and that's why it's called the intercalated segment. Intercalated meaning to insert among existing elements or layers. And so the motion is entirely dependent on the surrounding articulations and the crossing tendons. There are a lot of important ligaments in the carpus. Arguably some of the most important are the luno-triquetral ligament and the scapholunate ligaments, and that's what we're going to focus on today. So the SL ligament is a C-shaped ligament, obviously between the scaphoid and the lunate, that has dorsal, central, and volar subregions. The dorsal is the strongest. It has the thickest, and it has transverse fibers. And this is important because it resists diastasis, especially in the proximal portion, as we'll see. So the central portion is actually not a true ligament, more of a fibrocartilaginous structure. And the volar portion is palmar to the radioscapholunate ligament with thin oblique fibers. The luno-triquetral ligament also has three subregions. In contrast to the SL ligament, it's kind of the opposite in terms of what's most important. So the palmar region is actually the strongest, although the dorsal portion is most important for rotation. The proximal portion has little constraint potential, and importantly for the case of the luno-triquetral ligament, cadaveric studies have shown that transection of just that often will not create instability, and you need severing of extrinsic ligaments, including the dorsal radiotriquetral and the dorsal scaphotriquetral ligaments to infer stability. The biomechanics is kind of the crux of the matter here, and this is the most critical part. So the proximal row should move as one unit, although the carpal bones will move differently a little bit in relation to each other. So for example, in our range of motion, an arc of motion, 120 degrees flexion extension, the scaphoid will move 35 degrees more than the lunate. That said, the way this works, this picture at the top is a great example of kind of how the lunate is being suspended. So the lunate is balanced between the flexion bias of the scaphoid and the extension bias of the triquetrum. So in flexion or radial deviation, this distal row will drive the scaphoid into flexion, and the lunate will follow suit through the SL ligament. In contrast, with ulnar deviation, the hamate will engage the triquetrum, forcing it dorsally, and the luno-triquetral ligament will transmit that extension moment. And just to finish things off, interestingly, in extension, the extrinsic ligaments will actually lock the proximal carpal row together with the capitate, and they move in unison as a conjoint extension. So when these ligaments are disrupted is when you get the pathologic state. So disruption of the ligaments leads to a form of carpal instability dissociative. Dissociative meaning that the disruption is between carpal bones in the same row. So disruption of the SL ligament will lead to dorsal intercalated segment instability. That is, the lunate is now separated from the scaphoid, and while the scaphoid wants to flex, the lunate will extend or move dorsal. So it's in relation to the lunate, and that's how you get DISI. That's the most common form of CID. The opposite of this is disruption of the luno-triquetral ligament. So the lunate, or the triquetrum, wants to extend, but the lunate will not go with it anymore, and it will lead to volar intercalated segment instability, and this is the second most common form. So we'll talk a little bit about each. So in terms of DISI, it most commonly results from a fall or a higher energy mechanism. It may present acutely, but it may be subacute. The synovitis from a subacute injury can accelerate attrition that can potentially lead to disruption, but usually repetitive stress alone without a prior acute injury is unlikely to rupture the SL. The patient may present with weakness, pain with loading, as well as decreased grip strength and some painful popping. And on exam, we classically think of scaphoid tenderness kind of in the anatomic snuff box, and you can have radial snuff box swelling in the case of an acute injury, but oftentimes they will have more dorsal pain over the scaphoid, which is once in mediastinal blisters, and then if you can find it, the interval between the lunate and the scaphoid. So pain with extension or radial deviation, which makes sense based on the mechanics that we talked about. And then there's the scaphoid ballotment test, which is kind of a shuck test. You basically hold the scaphoid and you hold the lunate and you move them relative to each other, and positive is translation and or pain. And then the classic one that we always think of is the Watson test. And this is actually testing for dynamic instability. It doesn't really tell you anything about static instability. And basically what these pictures do a pretty good job. So you start by taking your thumb and pushing on the prominent palmar aspect of the scaphoid, which is the distal portion of it. You push it dorsally. You start ulnarly deviated and you radially deviate the wrist. And if there's a disruption, what that's going to do is push the proximal pole of the scaphoid up and over the dorsal lip of the radius. And then when you let go, it's going to spontaneously reduce and pop into place. And that clunk, and more specifically, clunk with pain, is indicative of an injury. People with hyperlaxity can have false positives with this, so it's important to check the other side as well. In terms of imaging, standard x-rays can be helpful for static instability. So a PA radiograph is very important. We think of the classic Terry Thomas sign, which is gap widening greater than 3 millimeters. We all know this picture. I looked into it a little bit. This is called diastema, which is kind of interesting. So if you're looking for an updated version, this is apparently a big deal in the London fashion scene. So I'll leave it to you to look up that. So another thing that you may see is signet ring view of the scaphoid, and that's a result of the scaphoid flexing. And so instead of looking at the scaphoid kind of as we normally see it, it's rotating. So we're looking down the poles basically, and so you get the signet ring sign. The other thing that you may see on this view, if that occurs, is you may see an extension of the lunate. And so instead of seeing the trapezoid shape that we often see, it's more of a triangular view. And then in terms of the lateral, that's kind of what we think of in terms of measurements. So true lateral is very important. When I say true lateral, I mean that the radius, the lunate, the capitate, and the third metacarpal are all collinear. And you can measure the scapholunate angle in this case. And what that is using the reference at the top here, it's the angle between the axis perpendicular to the line between the transition from the convexity to the concavities of the lunate, kind of that half moon view, and the axis of the scaphoid poles. So normal is 46 degrees, the range is 30 to 60, and in the case of DISI, because the scaphoid is flexing and the lunate is extending, you get an increased angle. So people say greater than 60 or greater than 70, I also saw. Stress views can be helpful for dynamic instability, clenched fist views, for example, or stress views, flexion, radial deviation. MRI, it's interesting. So we think of MRI as kind of being very helpful with ligamentous injuries, but in this case, it's often not. And I found a huge range in the sensitivities and specificities, and a lot of it depends on the quality of the MRI, 1.5 versus 3 Tesla, and also the quality of the radiologist is very, very, very important in this case. Diagnostic arthroscopy is actually considered the gold standard, and it kind of surprised me a little bit to start, but basically because this can be very difficult to diagnose, people will often go to a diagnostic arthroscopy, and there's a Geisler grading system, which we can talk about if we have time, but it's basically grading the level of injury based on arthroscopic findings. And then obviously if you're there, you can perform any therapeutic interventions you'd like. So speaking of treatment, so partial or occult injury, can start with splinting. Some people will move to arthroscopic debridement because they can diagnose it that way and also perform the debridement and potentially a percutaneous pinning. And then capsulodesis is also an option. A couple options are the black dorsal, and then the dorsal intercarpal ligament is often used sometimes. Moving on, it's dynamic instability. That is that we see gapping or changes on stress testing of x-rays. Some people will use the arthroscopic debridement. Screw fixation, repair, reconstruction, and capsulodesis. Reconstruction is typically, or traditionally, I should say, the Brunelli, which is where the FCR tendon is passed through the scaphoid tunnel. More recently, some people have used the tri-ligament modification, where they actually weave it through the radiotriquetral ligament first, then to the lunate. In terms of a static acute injury, which is common with perilunate dislocations, for example, you can repair it if it's viable, you can reconstruct it, or you can perform a capsulodesis. And then in the case of static chronic, if it's reducible, again, you can go back to capsulodesis or reconstruction or screw fixation. It's very unlikely that you're going to be able to repair it in that case. If it's irreducible or they have SLAC, that is scapholunate advanced collapse, which is basically you've had the insufficiency long enough, the deficiency, that you end up with arthritic changes. Then you move on to potentially intercarpal arthrodesis, four-corner fusion, or proximal row carpectomy. In terms of VICI, it most often occurs from a fall with extended wrist, and then in pronation as an isolated injury. And the pronation is important here because of the ulnar and volar ligaments will be stressed without the corresponding scapholunate stress. It may also occur, though, in conjunction with SL injury, as is part of the perilunate dislocation, and it can also be attritional from degenerative or inflammatory arthritides. They may present with ulnar-sided wrist pain. There's kind of a big differential there, but that's something they may have. They may have tenderness of palpation at the LT joint. And then the Reagan test is similar to that Ballotman test, kind of a shucking test. And the Kleinman shear test is this picture here where the pisiform and the triquetrum are loaded, and then the lunate is held. And as you push the pisiform and triquetrum, you may get pain as well, or translation. In terms of imaging, In contrast to SL injury, where you see gapping, you will not see this on lunotriquetral injury, because in LT dissociation, the triquetrum actually translates proximally. So you won't see a gap, but you may see overlap, or you may see a break in Galula's lines here. Lateral X-ray, again, we go back to the SL ligament. It may show a decrease in SL ligament because, again, the scaphoid and the lunate are moving together in this case abnormally, and so it may be less than 30. Other people talk about the LT angle and the CL angle, but that seemed less common. And then again, arthroscopy is the gold standard. In terms of treatment, acutely, you can repair to viable. This is an example of repair with suture using K-wires for the bone tunnels. Chronically, reconstruction is more common. Oftentimes, the radial strip of the ECU will be used to tether the lunate and the triquetrum together. And then arthrodesis is another option, but it was found to be uniformly not very good compared to reconstruction or repair, not just in terms of range of motion, but actually pain and complications as well. So in the interest of time, we'll skip the summary. These are my references. I'd like to thank Dr. Richard for agreeing to help lead the discussion, as well as the hand team, Dr. Roosh, Dr. Goldner, and Dr. Leversedge. And just a couple points that I thought were interesting as we move forward is the true role of arthroscopy diagnosis when you pull the trigger as to when to do it. Treatment choice for really any of these, which I thought it seemed like there was a lot of variability. And then the approach to the perilunate dislocations and instability as there can be multiple forms of it, and then also the SL and the LT ligaments can be involved in both, and how do you go about treating that?
Okay. Great job. That is a lot of information in 10 minutes. And in our discussion before, I didn't think you did really good, so that was great. There are a lot of great discussion points coming out of that, and I think we'll probably focus on the DISI side just because that's more common, but just as a takeaway, because there's a lot of complicated stuff in here that outlines and figure out as like a PGY3 or so, but the knowledge continues to come as you get older and older and start to see this more and more, that it's much more complex than we think. So naturally you think of DISI, you think of scapholunate, you think of VISI, you think of LT, but if you're looking at a film with a static deformity, what are the secondary stabilizers that everybody has to think of that have to be going on in order for you to have that static deformity?
So for the static deformity for DISI, the secondary is scaphocapitate, and then the scaphotrapeziotrapezoid. I think I'm saying it right.
Correct.
And then for VICI, it kind of came up in that Cadbury study a little bit, but there's extrinsic stabilizers, the dorsal radial triquetral, and I also saw the dorsal scaphotriquetral ligaments as well.
Exactly. So that's a very important thing, and it gets towards the reconstructive side. So if you're looking at a static deformity, you've got more going on than just those ligaments. And specifically talking about the scapholunate, one thing that I think is underappreciated is that it's not truly a band of tissue between the scaphoid and the lunate. It's a C-shaped ligament, as you pointed out, with a volar, proximal, and dorsal. So it's around the periphery of the scapholunate articulation, with the dorsal piece being the most significant structurally. And then when you lose the STT capsule and ligaments and the SC ligament, that's when you can fall into the scaphoid flexion and get your DISI deformity. And the other big thing about reconstructing it is that it's not just gapping. I think most people think of it as that gap. And then when you add that other layer, you think about the flexion and the scaphoid. But there's a third component too, which is pronation of the scaphoid. And when you reconstruct it, when you do a good reconstruction, you're really correcting that pronation. And if you think about it, the mid-caudal joint is a curved surface on the capitate, and the scaphoid will pronate right around that surface. So you have to supinate it back when you pull it out in extension and close that gap to get a good reconstruction. But I know Dr. Roosh and Dr. Goldner here, so I think your idea of arthroscopy and diagnosis is a very good one, because what I have trouble with and what I'd like to hear is when you see a patient in clinic and you're trying to put them on that treatment algorithm of what you will do or can do, it is a weird discussion to be saying, I may be fixing it, I may be reconstructing it, I may offer you some type of fusion. It all depends on how reducible it is, what the cartilage surface looks like. So I think arthroscopy is very helpful, and I've used it more and more preoperatively with a very Boolean, if you will, if-then kind of consent, talking to them about all the options. But I don't find a better way around that other than staging it to be able to tell that more definitively if I'm going to have to do something fusion or PRC or salvage versus a Brunelli reconstruction.
Maybe also you talk about just initially make the diagnosis if it's okay, so just on the physical finds and the radius actually need more. But,
Well, I think first off, we need to kind of take a step back and say, why are you worried about this stuff? What difference does it make? And I think you touched on it with this lab credential. Kurt Watson described this phenomenon where if an SL ligament is left untreated, then the abnormal motion will result in premature arthritis. And that has led people to have a very heightened level of concern in this entity, particularly in young adults. I think that how long that process takes is the important thing. Probably it's a 25-year phenomenon. It's probably not like this is going to happen in 5 years, so therefore you need to jump on this now. So to Mark's point, if you're taking care of a 50-year-old who has a gap and wrist pain, the chances are that is not an acute injury, or it's an acute on chronic injury, and you're probably not going to be able to do much for that patient. So I think a lot of this is really what you're trying to accomplish for the patient, and it falls into two groups. One person is going to be somebody who's got true instability. Every time that they put their wrist in a dart thrower's motion, they get a clunk. And that person is going to require some type of stabilization, no matter what you think of. So arthroscopy is probably not going to help you. And then you've got somebody who has dorsal wrist pain with extension right over the SL interval. And that person you probably can help with just an arthroscopic debridement. So I think a lot of this is going to be based really on how old your patient is and whether they've got true instability clunking or whether they just have impingement type pain in the back. And that's, I think, we have to really kind of take a step back. And the final point I would make is you have to be a little nihilistic when you look at the literature on this. All of the options that you've discussed, screw fixation, reconstruction, Brunelli, et cetera, none of them have been consistently shown to change the scapholunate angle at all. So the original description, the scapholunate angle 71 degrees. After treatment, happy patient, scapholunate angle 69 degrees. We really did not change the natural history of this disorder. And so, as you go into your careers and you're thinking about what you're actually trying to accomplish, I think you have to be fairly critical of all of what we've been able to do.
did surgeries change the symptoms?
Yes.
Symptoms?
It's the hot poker technique.
Yeah. So I think that's actually one of a lot of times we do surgeries that will change symptoms people have acutely, but it's unclear what's going to happen really long term. So ACL is like that. ACL is we do surgery to make you feel better acutely, but it's unclear what's going to happen in 30 years.
Even though the gold standard is looking at the ligament and seeing how far, where, what, people want to realize it's not just, okay, we're going to go back to the low office scope. So the history, the exam, fluoro, looking at the wrist on the porosity and different stress views, AP clench chest, the MR can look, certainly the arthroscopy is a better look at the SL ligament than the MR. But sometimes there's other pathology of the carpus that you miss. Certainly the arthroscopy is not going to see interventional not going to see the mirror, not going to see other things. So there's a whole spectrum of ways to approach it depending on the patient. And then anywhere from breeding to reconstructing to repairing to reconstructing with a whole variety of different methods to fusion to cross-bone carpectomy to four-bone fusion, depending on the whole spectrum of whether it's just early SL change or advanced select. So it's a little bit of art, a little bit of science, and it's one area where you really have to is listen to patients, explain to them the pros and cons, and be sure that they're in agreement with what the easy for doing, and the downside on the good side.
Yeah. Good job.